data is the same thing. You have too much of it. You just are overwhelmed. You can't handle it. You don't know what to act on it. You may even view it as liability. And that's another role for AI. AI has to sort through what is it that's actionable, and then not only what's actionable, what do you recommend or what have others done that, and what can we expect from these actions so that you can make the decisions based off of that. I do think that there's this paradigm shift that we're moving away from where AI does everything to how AI interfaces with humans. And the only way to do that is by interfacing with the AI as you kind of move along into I'll call it a series of different decision steps. And that's how we have to start thinking about where AI is going to be applied. It's not like AI solves it. AI is interspersed in our decision-making process to make things better. And then we collectively use our own values and the patient's values to make these decisions. And then we get to the better outcome, which is ultimately the best outcome for the patient.
Welcome to How I Doctor, where we're bringing joy back to medicine. Today, I'm joined by Dr. David Rhew, infectious disease physician turned tech executive, global chief medical officer at Microsoft, and one of the few people who wrote a thesis on AI in healthcare back in the 80s before electronic health records even existed. I want to hear from David about what he sees from his vantage point at one of the largest companies in the entire world: technology, data, cloud, AI, connected to many of the world's biggest tech companies and the biggest health systems in the world too. But here's what I think makes our conversation really timely. We put together our off-call survey, and there was a paradox. 67% of doctors are using AI daily. 84% say it makes them better at their jobs, but 81% are still dissatisfied with how their organizations are adopting it. I don't think physicians are afraid of AI. They're afraid of losing control. David sits at the center, I think, of this tension. Dr. David Rhew, welcome to How I Doctor.
Thank you, Graham. I'm excited to be here.
I'll just jump right into it, talking about AI and physicians. Do you get the sense that we are really building technology that excites clinicians?
The technology continues to get better and better. So as most of the people that have experienced AI have found great value, a lot of it has been around, I'd say, more administrative type of tasks, making it easier for us to document, finding information, communicating with individuals. So to me, that's a fantastic start to how we can use AI. But that is not where it ends. In fact, there are so many amazing things we can do with AI that we haven't even begun to scratch the surface of. Things like access to affordable healthcare, rising cost of healthcare, finding ways that we can make things better, more streamlined. And as we start looking into this, we may find that AI's greatest potential may be in things that we haven't even started today.
Yeah, I that's kind of one of the reasons I wanted to talk to you today is I feel like you sit at such an interesting place where you have access to the CEOs and CMIOs and the leaders of all the health systems. And then also you have access to some of the smartest minds and the most connected minds of all the largest tech companies in the world. I mean, not just Microsoft. You have, I'm sure, connections to all the other big tech companies as well. Like, from your perspective, where do you see this in 5-10 years that we're maybe not even thinking about today?
Yeah, so the first thing I would say is we may be thinking about AI in a rather simplistic way, that there's a model that solves a big problem and you're done. When in fact, what we may find that the way to solve some really complicated problems is to break it up into sub-steps. Let's start with one of the hardest problems we face in medicine today, which is the diagnostic situation where a patient comes in with a whole bunch of complicated things, and we're trying to figure out what is it that the patient has, what tests do we order, things like that. And so one approach could be, well, let's create a super amazing foundation model that has all these capabilities and see if it works. It hasn't yet to this point been able to do all the things that we think. But what we did is we actually said, well, let's break up this diagnostic problem into 5 key steps. So the first step would be, let's gather the information and let's create a differential diagnosis. So we had an agent that took a look at the information and it said, what's the possibility? What are all the possibilities? And then it passed it on to a second agent. And the second agent said, well, based on those based on those diagnoses, what tests could you possibly order? So that's all it did. It just focused on what tests were possible. And then the third agent said, okay, we've got a diagnosis, we've got a test. What is the guideline or the evidence-based basis for that. So all it did is look for guideline concordance on that. And then the fourth said, well, what about the cost? These some are really expensive, some are less expensive. And the last one said, well, wait a bit, have we forgot something? They called it the challenger agent. And it was really through all five of these agents working together that we saw something pretty impressive, which was the performance for this when you compare it to expert physicians on these different use cases was about 20%. This was 4 times greater than that. So what did that teach us? That taught us that one big super, incredible foundation model may in fact not be the answer, but it may end up being a whole series of agentic AI that is broken up into specific subtasks that are all orchestrated in a way that allows us to be able to then answer and do things that are more impressive.
David, I have like 1,000 questions now. I think the first thing, I kind of thought that 2025 was going to be the year of kind of agentic AI in healthcare. Maybe it's 2026. I kind of think of it as, because you're able to have these models behave in different way because they're kind of looking at things from different perspectives, you're able to actually get higher outputs from all of them. Is that kind of how you think about agents in AI?
Yes.
Yeah,
Yeah, and in fact, even when we started, and I'll just go back to when ambient started rolling out.
sure.
People were like, "Oh, it's because we've got agentic AI, the large language models. That's what's doing it." Well, let's break it down into the different tasks. Actually, the very first task was identifying who's speaking. That's not agentic AI. That's what we'll call traditional AI ML. The second thing was taking the words that you were saying and converting those words into text. That's traditional natural language, natural language, NLP, natural language processing, and that was something that we've had well before the agentic or even the large language models. And then we had the generative AI, which put it all into a note. And then we had integration into electronic health record. And so we did actually was we pieced together a series of different steps that involve different forms of AI. So I think the way to think about it is, don't think of AI as just one type of large language model or foundation model, but think of it in terms of a portfolio of different types of capabilities that, when applied to very specific tasks and stitched together, can lead to some pretty impressive results.
Well, and I have to see the corollary in traditional medicine of different specialties, right? I mean, I think we are all good at different things. I'm an ER doctor. There are things I'm really good at and things I'm not so good at. And that's why I might consult a hospitalist or an infectious disease doctor. I mean, so in the same way, like, agentic AI is kind of somewhat how humans have decided to break down medical tasks, or why we have a physical therapist, or why we have a speech language pathologist. Like, we have these other roles because we know we cannot all be good at the same thing. Humans and human biology is just too complex. Really, whenever I write about AI or think about AI, it really just makes me appreciate how incredible the human brain is, honestly. Like, you said that you had to, in your study, you had to break it down into 5 agents, but like, our human brains are just doing that automatically. Like, just how incredible it is that we can have, you know, 5 large language model agents sitting inside a human cranium and, synthesizing all that together. The more I use AI, the more I understand it, the more I'm just, frankly, like, in awe of the ability of human biology and neurons to do so much of this, and for us to take it for granted that we have to break this down because we don't even know that our brains are doing this for us.
Let's think about the patients that actually didn't come to clinic. These are the folks that either have a disease, but they don't realize it, or they have a disease they don't realize has progressed. And by the time they come in, it's usually too late. They've had a stroke or a heart attack or some other really bad scenario. And so what we have found is that we can now use AI to go out in the communities and screen for for disease. So I'll give you a couple of examples. In Los Angeles, working in collaboration with many of the health systems there, they hosted a health fair. They had education on a variety of different types of diseases. So there's awareness there. They had ability to check your blood pressure. They had ability to, potentially get vaccinations, hearing for the kids. But one thing they did, which was unusual, is that the people who attested to have diabetes actually got their eyes checked using a box, like a machine. It's like and within this machine, it within 2 minutes came back with the result. And they found that 67% of the people that just came in, just walking off the street, just looking to get their eyes checked, 67% had referable disease. And it wasn't just eye disease, but it was things like hypertensive retinopathy,
Sure. Diabetic
blood pressure,
retinopathy. Yeah. Yeah.
diabetic retinopathy.
Yeah.
And
Sure.
so it was incredible. These are people, in fact, one of the persons had just seen their ophthalmologist a few months earlier and was told everything's fine. Well,
Huh.
actually, we had an ophthalmologist there reviewing the films, and they
Yeah.
said, no, things aren't fine. You got to go see the ophthalmologist. And so, we're finding there's a lot of disease that's out there that's unmanaged or poorly managed. And then in Texas, they started putting this technology in the ambulatory clinic. So everyone that came in started getting just a routine eye exam as part of their vital signs. And what they found was that 20% of the individuals that got screened, 1 out of every 5, had advanced stage diabetic retinopathy with a hemoglobin A1C on average of 10.5%. So it is insane, like the amount of disease that is out there and how bad. Now, the excellent thing about this is it identified the high risk individuals, and those high risk individuals are being triaged to care, and will ultimately, if they can continue to follow up on the care, will get potentially a better outcome than if they had not been identified. So we're finding that we have now an opportunity to really change the whole trajectory in terms of who comes in. It's not just whether you actually have symptoms, because a lot of these people actually thought their blurry vision was just they needed new glasses.
Yeah.
But
Yeah.
but it's now we're finding them and we're saying, hey, no, we're going to put people on you and just make sure that you get the care, and you're now in our high risk category.
Hey, today's episode is brought to you by Abridge. We all feel the weight of clinical documentation that follows us home and chips away at our personal time. With Abridge, clinicians can change that. Abridge drafts a structured, clinically useful note at the point of conversation, all seamlessly integrated into Epic and customizable to your specialty while you review and finalize every word. Clinicians have reported significantly less after-hours charting, improved satisfaction, and dramatically lower burnout. Let technology support your day instead of interrupting it. Visit abridge.com to learn how you can focus more on patient care and less on paperwork. Let's put the care back in clinical care. A quick word about today's sponsor, Evidently. Their platform turns an ocean of fragmented clinical data into concise, actionable insights. Chart summaries, note drafting, denial appeal support, HCC capture, so you spend time caring, not chasing. A transplant surgeon at a large academic medical center recently took transplant referral review from 2 hours to 20 minutes with AI-assisted chart review from Evidently. Physicians deserve workflows that improve accuracy, reduce exhausting chart biopsy, and help us practice at the top of our license. If you want to see how this might work in your hospital or your department, go to evidently.com. That's evidently.com to get started today. Yeah, I mean, I think the world that seems really exciting to me is, one, targeted screening, being able to find the highest risk people and go after them. When everybody just says, "Oh, my vision's a little blurry," or "I'm a little dizzy," or something like that, and then turning that into these people are high risk and these ones aren't. And then the second one is just that we may be able to get really far with existing technology. That we don't necessarily need a new type of MRI scanner, or we can use a retinal camera, we can use an EKG, and there is actually
That's right.
plenty of signal for us to uncover stuff, and at a level that is actionable. That we don't need to necessarily invent a new blood test in order to find some discriminatory value between a high risk and a low risk person.
So there's a couple new paradigms that we're introducing with the technology. One is this concept of pre-screening. We're not actually trying to make a diagnosis, but we are trying to triage better. People that normally would not have gotten care are now being asked to seek care for further evaluation. So that's like a new concept. But then the second is AI can help us risk stratify. And then once it risk stratifies, it allows us to be able to allocate resources more effectively. And we know that 5% of the population in general accounts for 50% of the total cost of care. But if we can get to them earlier before they have the events, we can actually prevent those costs of care from cascading into very large amounts. And so this allows us to be able to think about how we can allocate resources. And something that Kaiser Permanente has been doing, but I think is a model for all organizations, is rather than sending the vast majority of other folks into the primary care system, they're managing them digitally and virtually. And so they actually don't get brought into the system. Turns out that even with ophthalmologists and other specialists, 80%, we did an informal survey of the ophthalmologists that we surveyed. They said 80% of the patients they see are just routine follow-ups. And they actually are the 20%. Now imagine if you had a mechanism to bring in the higher risk folks that need procedures. You've changed the whole dynamics in terms of your availability of these precious resources, which are subspecialists and people that can do procedures. And that's what we have to think about. We have very little resources. Use AI to help us with resource allocation.
You are reminding me I'm due, I think, like in the next couple of weeks for my ophthalmology screening appointment. I've got glaucoma suspect. I don't even know what that means, but it's like a friendly, casual visit with my ophthalmologist, and we mostly chit chat. Like, is that the best use of his time? I'm sure he loves talking to me, but
And you can do this outside of the eye clinic as well now. We can move
totally,
this
yeah.
to primary care, retail, even a kiosk, or potentially at someday at home.
Let me ask you a question that was posed to me by a Midwest breast surgeon, and I didn't have the answer. And I'm curious if you magically do, David. So I told her this idea. I specifically was talking about mammograms and kind of this idea of like a high risk normal that, like, yeah, we are not saying that your mammogram today shows cancer. We are saying that some of the pixels look like you might have cancer in a year from now. We're not saying that you need a biopsy today. But this breast surgeon said she was worried. She said, Graham, I see all the possibility. I see the promise. I get it. I love this idea of catching earlier tumors. But we can barely keep up with the number of mammograms that we need to do already. How are we going to handle this when AI is going to find all of this new disease burden? My answer for her was that, I think we will probably move to some more risk-based screening approaches. If we find all this disease, we need to have the bodies, the people, maybe just the systems to handle it all.
Absolutely. There's really three components to a broader population health strategy. One is we need to find people that are, I'll call them ticking time bombs.
Yeah,
These are individuals that have disease that is out of control, but they don't realize it. And in all likelihood, by the time they realize it, something bad will happen. The second is around how do you manage this? And this is exactly what you're talking about. Risk stratification is an incredibly important element. You can combine that with human as well, but ultimately there has to be some mechanism to say that these are people that need to be treated and seen right away, whether it's for a procedure or something bad is going to happen. Like, for instance, one of the things we've been talking about with the retinol is if we could potentially stratify to say, based on what we're seeing, we think your blood pressure is over 180. I mean, we know people that walk around with a blood pressure of 180, hey, bad things are going to happen. So you've got to lower that. Now, if they're like 160 or whatever, it's bad, but it's not like urgent. Okay, so I think we need to start thinking about like what are those levels that we act upon, and then you've got the capacity piece, and the question is, are we using our current resources most effectively? In the area of ophthalmology, it turns out that many of the routine follow-ups can either be done through these reading centers or through optometry. Actually, there's a
sure.
lot of optometrists that could do this, and we need to start thinking about how we manage those resources, and in many ways, push us to practice at the top of our license and help support those with AI and other tools to be able to practice at a level that's even higher than what they currently do. And then the third is we have to figure out a way to get these individuals to stay adherent to these programs. This is around disease management. This is not about like one-time interventions. This is about helping people to basically take care of themselves. And our ability to be able to help better manage those individuals and support those individuals on their journey is sort of that third challenge. And that's actually one of the big lessons learned for AI. A lot of times we think we solved the problem, but all we did is we exposed the problem that's just downstream. And so then we figure out like, oh, well, we got to solve that. And then we expose as another. So we got to think end to end about like what's the overall process, figure out the strategies for all of them, and then stitch it all together.
David, it's so fun to talk with you about this. You're so passionate about it. You sound like you are a healthcare executive. Like you're thinking about these big picture ideas, but you work for Microsoft. So I'm so curious, like, what is it that you get to do every day from your position? Is it that you're like connecting these people with similar ideas and bringing them together to do studies? Are you funding this research? Are you, helping bring the best ideas up to the top?
I see myself as a translator, both internally within Microsoft and externally to our clients and our partners. There's amazing technologies that we have today that can do some incredible things. But oftentimes people look at them and say, well, we evaluated and it didn't quite work. It's like, well, wait a minute. Did we use the right metrics? Ambient would be a great example. People said people are going to be far more efficient. They're going to see 10 times as many patients.
Yeah.
Well, okay, first of all, what was the reason what we started with ambient? The clinicians were burned out. They're leaving the practice. This was the primary reason that we started with this. The second reason, which I think was sort of forgotten, was that the patients were saying this experience is not so good. The docs are not even paying attention, or the nurses are not paying attention to me. And what we found is that the ambient actually does a great job in terms of being able to reduce the psychological burden that we've been seeing. And so the burnout has diminished. We've seen that the administrative burden has diminished, and that the ability for people to pay attention to patients has dramatically increased. So what am I here for? I'm here to say, hey, listen, if we're going to measure these things and show its value, let's make sure that we measure it in ways that make a lot of sense. But at the same time, I'm also trying to say, hey, let's not forget about the big picture items, because this technology can solve the problems we see now, but it can also solve things that we haven't even thought of. So getting people to understand that we're on a journey together, and the technology needs sort of a translation into clinical practice, and I'm here to help with that translation.
When you think about ambient, and I'm thinking about this again as like we're really early in this. The current usage is like I pull out my phone, I hit record, and then, voila, in a minute or something like that, my note gets written. Do you have ideas with or you and the DAX and the Copilot and the Nuance team? Do you have ideas of like what 3-5 years in the future looks like?
Yeah, I think that there's many different paths. One is just on the fact that things have been digitized. We can do things that are going to allow us to be able to use that digital footprint of that conversation and identify many more opportunities for either clinical decision support, streamlining care, improving reimbursements, prior authorizations, things like that. So to me, that's like a path we're already seeing. Now imagine using voice in combination with some of the other things that we are capturing, like one's genetic information, and other types of omic information. So there's incredible opportunities to start combining these different data sets and getting a 360 view of what's happening with individuals, but not just also in the clinical encounter. Use voice potentially as a means where people, as they're communicating with their own personal navigator, their chatbot, to be able to help them on their journey. And so now we're starting to shift the responsibility of care being dependent on a clinical visit to now one that is empowering individuals through these technologies. So like maybe we see a shift in that direction. And then we haven't even talked about ambient vision, like
Yeah.
computer vision. And so like that's like an incredible opportunity as well. We're already seeing it for some basic stuff like, did counting sponges and the duration of the time, seeing who's coming in and out of ORs. But what we're also seeing is that we have an ability potentially to improve the surgeries and make surgeons better, to allow us to be able to democratize high quality care around the world. And these are the types of things that get me really excited because we're just scraping the surface of what's possible.
There are probably near limitless ideas and on how we could use this technology. And I'm sure you hear pitches and see decks from thousands of companies every year who have the latest thing that they want either your attention on or Microsoft to invest in, or whatever it is. How do you personally decide which one should I? Yeah, oh, maybe I should look into this more. Is it the scale of the addressable market, if we're going to use a VC term, or is it impact to certain communities? Like, how do you even think about?
I look at it from the perspective of what problem are you solving? And is it a problem that actually has been solved before? When you look at the TAM, are you looking at one component of the TAM, or are you just solving like a pain point within that TAM? And then the total addressable market was what I mean TAM. And then the other thing is, I feel like that many of the technologies today are solving the same problems just in slightly different ways. But then sometimes you run across a technology or an approach that is quite innovative, and there's something that's unique about this that you're like, wow, this could actually really change the whole trajectory. And so I'll go back to that whole retinal screening, because I think everyone's focused on the AI that is applied on the actual uh, image that is acquired. But I actually think the real innovation is the fact that we automated the data acquisition piece, because now there's a box, there's a machine that used to take 20 minutes for a clinician and a technician to capture it. It's now done automatically. That to me was the real innovation that is sort of missed in all of this, because everyone's so focused on the AI, but it actually, this automated data capture, which does not require an individual with expertise to do this. And that is the challenge that we have, because so much of it requires a doctor, some kind of a clinician, or some type of technologist to either acquire the image or read the image. But as soon as you get rid of that barrier, now you've democratized it. To me, that's the type of stuff that I look for. I look for things that are solving a problem that may not necessarily be the one that they were talking about. But when I look across the board, I say, whoa, so you didn't need the doctor, or you didn't need the technologist, and it took 2 minutes instead of 20 minutes. And all you need to do was push a button. That's the type of stuff that could really change healthcare.
Well, and I think the focus has been on physician challenges, where obviously probably the rate limiting step and certainly the most expensive step of the process. I know you guys are working on like nursing ambient tools, and I'm sure there are physical therapy ambient tools, because there are way more quantity of nurses in the United States than doctors, and speech language pathologists and MAs, and the quantity of people that could be helped with this technology is certainly way larger than just physicians.
Absolutely. I do feel that right now, again, on an ambient journey, we're still fairly early. The
Yeah.
number of use cases has really been limited, largely because it does have to be integrated into workflows, and we have to prove that those workflows are leading to meaningful value. And I think we have.
Yeah, David, you've even talked about digital twins before. Um, like, how do you see digital twins working in clinical practice, and how accurate do you think they're going to be?
The only way we're going to be able to create a real accurate model of what's going on is we have to have multiple different inputs, and we have to understand changes in those inputs as well. So the more continuous monitoring as opposed to the intermittent, the better our models will be. And that to me ties into some other things that we're starting to see, extraordinary things. Sensors are getting better. Our ability to make it into, you know, patches that are really inexpensive, that are capturing continuous monitoring, ability to actually use the patches to be able to pull and extract, um, I'll call it biochemicals from your system, so that normally would have required you to actually get a blood draw, now is actually being captured. So there's a whole series of innovations that are occurring around the data acquisition piece that then pull into our ability to be able to better monitor and create these monitors. We can actually do things that we have never envisioned before by pulling these data sets together and allowing us to be able to start thinking about how we can measure different performance. I'll give you an example. I was at Cedar Sinai recently, and one of the AI researchers was sharing a bit about the computer vision project that they were working on. And it really got me excited, because it introduced this idea that I think really is going to catch on, which is when you look at a surgery, there are some basic things that are happening. There's cutting, there's pulling back, there's
Yeah,
cauterizing,
retracting. Yeah, yeah, yeah.
tracting, and stuff like that. And so, just a very simple thing. They just said, okay, we're going to take a look at frame by frame. Are you a cutting? Are you doing this? And what they did is they actually mapped out an entire surgery
Oh,
based
interesting.
on all of that. And then they started comparing that with other surgeries. And then they started looking at outcomes associated with that. And it makes perfect sense because we do things we don't necessarily realize that there are certain kind of structures for how we're doing this. And so the more that we can start thinking about that, it allows the AI and the other tools to be able to better be more effective in terms of how we are approaching things. And that's something that I feel like as we build digital twins out, we're going to have those type of structures or frameworks because it gives us a better understanding of how to be able to compare and contrast between different procedures and different types of individuals.
If I'm a not a clinical informaticist, if I'm one of my colleagues working in the ER today that maybe is not, doesn't love talking about AI and data and informatics, some of this sounds kind of overwhelming. The idea of even more data coming to me when I'm working a shift in the ER or I'm working a shift as a primary care doctor or something like that. Seems like there needs to be a layer that's like data, this kind of data to information to knowledge piece. Like if I could accept more pieces of knowledge as a doctor, I probably would be okay with that. I would be terrified. I will be terrified if everyone's wearing sensorized clothes and their Aura ring and their Fitbit and their everything, and then they just dump this data in front of me in the ER and say, "Oh, hey, can you figure this out?" So I wonder if there's like a layer that we need, like, is translational, summarizing all this. So what gets to the human or the human plus the AI is a bit summarized as well. I don't know. Do you see that?
Yeah, absolutely.
Yeah.
I mean, we do know that too much of anything is not necessarily
Yeah.
good for you. And
Yeah.
as much as I love like my sweets and my candies, I know for a fact that's not good if I overindulge.
Yeah.
And so I think that data is the same thing. You have too much of it, you just are overwhelmed. You can't handle it. You don't know what to act on it. You may even view it as liability. So there's a lot of reasons that we have to put in that interface, and that's another role for AI. AI has to sort
Yeah.
through what is it that's actionable, and then not only what's actionable, what do you recommend or what have others done that, and what can we expect from these actions, so that you can make the decisions based off of that. I do think that there's this paradigm shift that we're moving away from, where AI does everything, to how AI interfaces with humans. And the only way to do that is by interfacing with the AI as you kind of move along into I'll call it a series of different decision steps. And that's how we have to start thinking about, where AI is going to be applied. It's not like AI solves it. It's AI is interspersed in our decision making process to make things better. And then we collectively use our own values and the patient's values to make these decisions. And then get to the better outcome, which is ultimately the best outcome for the patient.
Yeah, I could not agree more. That is kind of how I talk a lot about medical judgment, and that I don't know that AI ever will or should be making medical judgment. Right? Medical judgment is a mixture of uh, my understanding of what I think is going on with the patient. The patient's values are brought into that decision as well. And AI may help me understand the options and the choices, but that medical judgment piece, you know, probably should stay within the bounds of a human that's got a body that understands what it's like to, suffer and have pain and be anxious and be scared and all that as well. David, in our last few minutes here, I want to ask you, just because you get to you get to probably see the coolest cutting edge stuff. What do you think the big breakthrough in medicine, healthcare will be in the next 3 to 5 years that surprises us, that we didn't think was maybe going to happen or didn't think was possible?
Yeah, I still believe that there's a level of automation that will happen that is going to ultimately kind of change the trajectory of how we think of AI. AI has been traditionally about knowledge and just simply getting us to be smarter. But when AI is actually doing more complicated things and performing tasks that would normally have required an individual, and we're starting to see that, like with LASIK, for instance.
Sure.
Imagine LASIK being applied, that same type of approach where you have some very complicated issues now being done consistently by machines. Now, did LASIK replace the ophthalmologist? No, it actually made them much more effective in being able to address more disease. And so I think that there's this opportunity where we can take AI, apply it in ways that become much more agentic and automated and robotic, and then ultimately bring us to a point where we're working in collaboration to address the incredible amount of disease that's out there that we're finding with the other AI.
Yeah. I'll ask the inverse now. There's a lot of hype, maybe something that maybe it's not even hyped, but it's just it's going to take longer. Like anything that you think people are talking about right now that may just not happen in the next 3 to 5 years.
To me, it's about expectations, and sometimes the expectations don't meet where it's at. We know trajectory wise, in terms of its performance, it is on an upward slope. Whether it's exponential or it's linear, depending on how you're looking at it. But we know AI continues to get better, and the use cases and the validations are demonstrating a lot of value. I'm actually of the mindset that there will be some significant breakthroughs relative to how AI is applied both clinically and on the research side that in the next several years will kind of give people a greater understanding of some of the potential it may have in our lives.
Yeah. I'm in agreement with you. I don't think that AI is replacing physicians anytime soon. Certainly not in the 20-ish years I have left to practice. A couple of quick rapid fire questions for you as we wrap up. Fill in the blank. The most important skill for a physician in 2030 will be.
How to apply AI responsibly to deliver the best outcomes for your patients and for the system.
Oh, I love that. You wake up tomorrow, you're no longer global chief medical officer of Microsoft. You're back practicing as an ID doc. What's the first AI tool you implement in your practice?
It would be ambient. I mean, just because it's just, right now there's such a burden on the clinicians trying to figure out ways to document the encounters. I know for a fact it would reduce that, and that would be something that would be very valuable. So that's like for sure the first thing I'd use.
Okay, now here's my real question. Sometimes you guys find stuff like, they visited a petting zoo 2 weeks prior to their fever or something like that. Now, would ambient know that should go in the HPI because you're an infectious disease doc? Or is it going to be like, oh, that's totally irrelevant to the visit?
I think actually, this gets back to sort of the personas. If we were to
Yeah,
kind of build out ambient that is thinking from the perspective of an ID, we may have a completely different type of answer than if we're using ambient as from the perspective of a surgeon. And so we may again get back to the point of what we talked about before, have multiple different types of agents all kind of working together, thinking about different things, having that conversation, presenting the options, and then having a human decide what's most relevant.
love it. Dr. David Rhew, thank you so much for taking the time. It's been absolutely a delight. We could talk for another 3 hours, I'm sure.
It's been my pleasure as well. Thank you so much for having me.
Thanks for joining me today. For interviews with physicians creating meaningful change, check out offcall.com/podcast. You can find How I Doctor on Apple, Spotify, or wherever you listen to podcasts. We'll have new episodes weekly. This has been and continues to be Dr. Graham Walker. Stay well, stay inspired, and practice with purpose.